No.
Hey, it's recording too.
Yeah, we got it worked
That's
out.
because
Go ahead and
David
share.
figured it out. Sure.
Yeah, in the middle, green button. Yep. You could choose if you want to do like your screen or just that one. I would just do the application window on the left.
That
yeah.
one. Mm-hmm.
Hit share.
Sure.
Yep, and now you're there and you can just
Good.
Put that down to your
slideshow.
slideshow.
I
can
go back. It's okay. Go back to the top
go back and just start.
and play from the beginning. Perfect. There you go.
Okay. All right. Well, this is a talk on stimulant use disorders, and the idea was to do a review of the evidence that's out there. Please feel free to ask any questions that come up. It may be a little bit dry. We're just going through a lot of studies, but that was kind of the idea, is to go through a lot of studies and just review them and what evidence is out there. Okay, so just reviewing on why this is important. Stimulant use disorders are second only to cannabis as the most widely used class of drugs. In the past 10 years, overdose death rates for cocaine have increased threefold. Overdose death rates for other stimulants, methamphetamine, amphetamines, prescriptions have increased 12-fold. A lot of this is attributed to co-ingestion with opiates. At this point is where we're seeing the real mortality risk. Beyond mortality risk, of course, stimulant use disorder has really significant long-term health consequences on many body systems that could include particularly cardiac, pulmonary, cognitive, dental, and infectious complications. So this is just a graph looking at overall US overdose deaths from 99 to 2023. So the highest number right here is synthetic opiates other than methadone. This is primarily illicitly manufactured fentanyl, which is IMF. This is psychostimulants with abuse potential and cocaine. So you can see that's really just second to opiates. So very concerning for mortality risk. This is just another kind of graph of some of the same collection of data. And this is overdose deaths involving psychostimulants with abuse potential. This, as we can see here, the majority of these are also involving opiates. This is what this yellow line is, stimulants in combination with synthetic opioids other than methadone, primarily fentanyl.
Although there's still 10,000 deaths with psychostimulants without opiates.
Exactly. Yep. So we can see there's a significant increase in mortality based on stimulants alone and with combination of opiates, which we know is an ongoing epidemic.
Yeah.
First. So this is a review of the current guidelines that are out there. So this is a review of the ASAM guidelines for stimulant use disorder. So looking first at non-pharmacologic treatments. Number one, contingency management. That was listed with high certainty and a strong recommendation. And that's incentives that are given, such as like vouchers to reinforce positive behavior. Number two, the community reinforcement approach. This one has a low certainty. And this is a psychosocial intervention focused on helping individuals meet social and emotional needs in healthier ways, substance abuse. Cognitive behavioral therapy, low certainty, helps individuals challenge unhelpful beliefs and develop coping skills to manage triggers and cravings. Number four, the matrix model, which is moderate certainty. This is a 16-week program that utilizes various therapeutic interventions, including CBT, family therapy, and relapse prevention tools. Per ASAM, contingency management has demonstrated the best effectiveness in the treatment of stimulant use disorders compared to any other intervention study that represents the current standard of care. Unfortunately, less than 10% of addiction treatment programs utilize this, and there can be significant barriers to that. Regulations, financial costs, program resources. And also, unfortunately, we'll address this a bit later. Many of the benefits of this stop once the actual program stops. Now, where to put this one?
You can hit the little
This one?
yeah.
It'll minimize it. Thank you. Yeah. Okay, so more ASAM guidelines. This is pharmacologic treatments for stimulant use disorder. Unlike opiates and alcohol, there's no pharmacotherapies that have been approved by the FDA for the use of stimulant use disorder. Existing evidence for treating this with medications is low quality. Pharmacotherapy use is currently off-label. So this is looking at pharmacologic treatments for ASAM guidelines for cocaine stimulant use disorder. So non-psychostimulant bupropion, low certainty, it's conditional recommendation. We give consideration with co-occurring tobacco use disorder and depressive disorder. Topiramate, low certainty, we consider co-occurring alcohol use disorder. For psychostimulants, modafinil is low certainty. Extended release mixed amphetamine salts plus topiramate, listed as moderate evidence. We give consideration to co-occurring ADHD and alcohol use disorder. And extended release mixed amphetamine salts alone is low certainty. So ASAM guidelines, this is pharmacologic treatment for amphetamine type stimulant use disorder. So again, no pharmacotherapy is FDA approved. Non-psychostimulant, bupropion is low certainty. Bupropion IM plus naltrexone, moderate certainty. Topiramate, low certainty. Mirtazapine, low certainty. Psychostimulant, methylphenidate, low certainty. Amphetamine salts plus topiramate, low certainty. So the most that we have is moderate certainty with bupropion and naltrexone. So this is, now we're going to start just going into the studies that are out there and what exists in terms of evidence. So looking at topiramate, the study is listed down here in the bottom at blue. So this was a pilot trial of topiramate for the treatment of cocaine dependence. This was a 12-week double-blind randomized controlled trial, 142 patients with cocaine type stimulant use disorder. They were treated with CBT plus topiramate in escalating doses to 300 versus placebo. So the topiramate group had a greater proportion of cocaine non-use days, only by 13.3% versus 5.3%. In a 13-week randomized controlled trial, it's another study, 40 patients with cocaine use were assigned to topiramate 200 milligrams daily or placebo. The topiramate group was likely to achieve 3 weeks of sobriety and more likely to be abstinent during the last 5 weeks of the trial. This is per the ASAM Clinical Guideline Committee. When they reviewed the evidence on topiramate, they said they judged that the evidence only somewhat favors topiramate. They concluded that topiramate may be considered for patients with cocaine use.
And these are not overwhelmingly large trials by any means.
And that's kind of what this is addressing, is just what evidence is out there or substantial lack of evidence. So this trial, bupropion and naltrexone in methamphetamine use disorder. So this is a multi-site, double-blind, 2-stage placebo-controlled trial, 8 sites around the US. Naltrexone 380 milligrams IM was given Q3 weekly, Q3 weeks, and bupropion 450 milligrams daily in adults with moderate or severe meth use disorder. In the first stage of the trial, participants were randomly assigned to either the medication group or the placebo for 6 weeks. In the second stage of the trial, those in the placebo group without a response in stage 1 underwent re-randomization for an additional 6 weeks. The outcomes were measured by twice weekly UAs. Primary outcome was at least 3 out of 4 negative UAs. Response in stage 1, 16.5% in the med group versus 3.4% in the placebo. In stage 2, 11.4% in the med group versus 1.8% placebo. So authors' conclusions were the response over 12 weeks among participants who received meds was low, but higher than that among participants who received placebo. Here's some of their data in graph form. So this is again the response, which, as a reminder, this is at least 3 out of 4 negative UAs at the end of stage 1. So this is weeks 5 through 6. And this is the medication group versus the placebo group. This is another graph of the same data, and this is just meth negative urine samples over time. So this is not just measured in weeks 5 through 6. And as we can see, there does seem to be more response in the naltrexone bupropion group compared to placebo. Interestingly, it's not quite as significant in the stage 2 when they re-randomized the placebo group that did not have a response. But those numbers seem to be stronger than when we're looking simply at weeks 5 through 6. This study is looking at modafinil, efficacy and safety of modafinil for treatment of amphetamine type stimulant use disorder. This is a systematic review and meta-analysis of randomized controlled trials. So this one looked at data from 5 randomized placebo-controlled studies. The authors noted there were other studies of modafinil. The authors noted this one is unique in that it looked at a wider range of outcomes. There was 9 total. I didn't list them all, but they also included cravings, significant adverse events, retention and treatment. They noted this was unique in that it did not pool data with other psychostimulants and looked specifically at amphetamine type stimulant use disorder. Prior meta-analyses did not find modafinil was helpful with increasing abstinence. So this study found modafinil did not significantly impact amphetamine type stimulant use, retention and treatment, or treatment discontinuation. Results were consistent when they did a subgroup analysis, looking at both 200 and 400 milligrams daily. Authors concluded there's currently no evidence suggesting that modafinil has statistically significant effect on efficacy outcomes in populations with amphetamine type stimulant use disorder. This is looking at mirtazapine for the treatment of amphetamine and methamphetamine use disorder, and this is a systematic review. So this one included 2 placebo-controlled randomized controlled trials were included. Study population was cisgender men and transgender women. The kind of idea or thought behind this is as mirtazapine increases dopamine, norepinephrine, and serotonin levels in the mesocortical limbic system, that this may alleviate, increased monoamine levels may alleviate methamphetamine or amphetamine cravings, withdrawals.
Katie, can I ask a question?
Yes.
Why did they choose to study cisgender men and transgender women?
So this is like a significant thing I was finding with a lot of these studies, and they were really limited. That many of them tend to just really favor a male population. Some of that just comes down to like the treatment center that they had access to.
This was treatment center.
All male treatment center option. And so some of that is just like the study population that they have.
These were out of the same treatment center in San Francisco. They did a lot of HIV clinic work, so there's a lot of men having sex with men, and honestly, in that grouping as well. So just out of the same clinic, essentially.
Yeah.
Okay.
So mirtazapine, they concluded it likely results in a small reduction in continued methamphetamine use compared to placebo. This was only felt to be moderate certainty evidence due to imprecision. On retention, they found it likely has no impact. On high-risk sexual behaviors, that was unclear. Depression symptom severity, little to no difference, and cravings, insufficient data. So once again, just difficulty with even having this population widely applicable to a generalized population, difficulty even eliciting a clear response within this population that we have. This one looks at pharmacologic treatment of methamphetamine and amphetamine dependence. This is a systematic review from 2020. So this looked at 43 studies, collectively enrolled over 4,000 patients. 23 individual pharmacotherapies or alone in combination were reviewed. I didn't list all because it's just too long, but medications included 5 antidepressants, which included an SSRI, mirtazapine, bupropion, a tricyclic antidepressant, topiramate, antipsychotic, methylphenidate, dexamphetamine, gabapentin, naltrexone, bupropion, NAC, and a benzodiazepine. Meta-analysis was not possible due to different outcomes and measures. Overall, again, as we're kind of seeing with some of these studies, 70% of the participants were male. About 70% were dependent on methamphetamine only. Reviewing their evidence, they concluded contingency management demonstrated a significant reduction in use, plus minus CBT, but effects were just not sustained after cessation of the program. Residential rehab decreased use at 3 months versus no treatment, but the effect was not maintained at the 3-year mark. They concluded no pharmacotherapy yielded convincing results for the treatment of amphetamine or methamphetamine dependence. Mostly studies were underpowered and had low treatment completion rates. So that's another significant barrier with these, is getting good follow-up, getting long-term follow-up. They just kind of reviewing how they did this study. 79% of studies that they looked at in this excluded participants with comorbid mental health diagnoses or on medications prescribed for mental health.
No, yeah.
Okay.
So
All right.
that's a very large. Why does this matter? Research suggests that transient psychotic symptoms are observed in up to 40% of methamphetamine using populations, possibly more in treatment seekers. 42% of people who use methamphetamine in the past year also reported concurrent mental illness. This is 3 times as high as the non-illicit drug using population. So the exclusion of relatively common comorbidities, such as polydrug dependence and mental health comorbidities, limits the generalizability of many of the studies.
Yep.
So again, a lot of inconclusions and data lacking. So on to psychostimulants for stimulant use disorder. So this is another off-label medication. I can't remember that today. Off-label medication being investigated. Arguments in support of this include that similar to how opiate agonists like buprenorphine and methadone are used in treatment of opiate use disorder, prescription stimulants may provide similar agonism to relieve withdrawal symptoms and prevent or reduce stimulant use disorder. So psychostimulants for cocaine dependence. This study combined or looked at 26 studies involving over 2,000 participants. They assessed 9 drugs in total. bupropion, dexamphetamine, those are listed there. They concluded they found very low quality evidence that psychostimulants improve sustained cocaine abstinence, but it did not reduce cocaine use among people who continued to use it. They found moderate quality evidence that psychostimulants did not improve retention and treatment. This one looks at prescription psychostimulants for treatment of amphetamine type stimulant use disorder, systematic review and meta-analysis of randomized placebo-controlled trials from 2023. So this included 10 randomized controlled trials in their meta-analysis. They studied methylphenidate from 54 to 80 milligrams. As a reminder, max ADHD dose is 108 for that. And dextroamphetamine from 60 to 110 milligrams. And 50 milligrams is typically max ADHD dose for that. And this was over 2 to 24 weeks. They found stimulants did decrease endpoint cravings, but this did not reach significance for amphetamine type stimulant use disorder when measured with UAs. So there's some subjective report from people, but not enough when we're looking at objectively looking at UAs. No effect observed for self-reported amphetamine type stimulant use, retention and treatment, early stage cravings, withdrawal, or depressive symptoms. In a sensitivity analysis, treatment was associated with a statistically significant reduction in UAs positive for amphetamine type stimulant use. This was after they removed studies with a high risk of bias. And in a subgroup analysis, methylphenidate and high doses of prescription psychostimulants were negatively associated with amphetamine type stimulant use by UAs. The greater benefit was found with high dose prescription psychostimulants. However, only one study had over 162 milligrams of methylphenidate. There was a moderate risk reduction for amphetamine type stimulant use. Such difference in treatment effects was not present at lower doses. This is looking at extended release mixed amphetamine salts versus placebo for comorbid adult ADHD and cocaine use disorder. This was a 13-week placebo-controlled randomized controlled trial, 126 participants that had both ADHD and cocaine use. Participants received extended release mixed amphetamine salts, 60 or 80 milligrams, or placebo plus daily. So it was like a 3-arm trial. More patients achieved at least a 30% reduction in ADHD symptoms in the med group. Rates of continuous abstinence in the last 3 weeks were greater for the medication groups than for placebo. It was greatest for 80 milligrams at 30%, 17.5% for 60 milligrams, and 7% for placebo. The author conclusion on this one was that extended release mixed amphetamine salts in robust doses, along with CBT, are effective for treating co-occurring ADHD and cocaine type stimulant use disorder, both improving ADHD symptoms and reducing cocaine use. And as a reminder, per up to date for Adderall XR, they say rarely is over 40 milligrams necessary. 60 milligrams is considered the max daily dose. So these are what is referred to as robust doses, is up to the 80 milligrams.
Were there increasing side effects or anything commented upon? I'm wondering at the higher dose ranges.
I don't recall.
Okay, I'll look back.
From that
I'm just
study,
curious
yeah.
because often in some of our trials we see that, right?
Mhm.
So
So did they all receive CBT?
Yep.
Oh, so they all had CBT?
Yes.
Okay.
Yeah.
Sorry if I didn't word that well. Yeah, it was
Yeah.
either 60 or 80 or placebo. Everybody had CBT.
often that was the signal, right?
And again, why can this be important? Rate of ADHD is 2.5 to 4% in the general population, but up to 10 to 24% of those seeking treatment for stimulant use disorder. This is a study, the Association of Pharmacologic Treatments and Hospitalization and Death in Individuals with Amphetamine Use Disorders in a Swedish national cohort of almost 14,000 patients. This looked at individuals from 2006 to 2018. They were ages 16 to 64 living in Sweden with a first-time diagnosis of amphetamine or methamphetamine use disorder without previous diagnosis of schizophrenia or bipolar disorder. Again, this one leaned heavily towards the male population. 69% were male. Mean age was 34.4. Their primary outcome was hospitalization due to substance use disorder and any hospitalization or death. A secondary outcome was all-cause mortality. Looking at their study population, this is what prescription medications they were on. 54% were taking antidepressants, about 45% benzodiazepines, 36% antipsychotics, 28% ADHD meds, 10% specifically taking Vyvanse, 20.5% taking substance use disorder medications, and 12% taking mood stabilizers. This study did not differentiate the reason for stimulant prescriptions, meaning was it specifically to treat ADHD, or was there another indication, or was this an off-label use for stimulant use disorder? 74%. So looking at the outcomes that they measured, they were important outcomes of the population that they looked at. 74% during this time period were hospitalized due to substance use disorders. 82% were hospitalized due to any cause or died, and 9.5% died of any cause. What they found, so this is looking specifically just at oral naltrexone. That was not associated with a lower risk of hospitalization or death. Buprenorphine was associated with a significantly lower risk of any hospitalization or death. Topiramate was not associated with either increased or decreased risk of outcomes. Antidepressants as a group were associated with a statistically significant increase in risk of hospitalization or death. And mirtazapine and bupropion were not associated with any outcomes. And some of this may be due to comorbid or coexisting conditions as opposed to the actual medication effect. And again, kind of like we talked about earlier with the increased risk of stimulant use death when you're combining opiates is probably some of this effect of the buprenorphine that we're seeing that results in the low risk of any hospitalization or death. So co-occurring use disorders. Vyvanse was the only medication that had a statistically significant decrease in risk of all three outcomes, which was stimulant use disorder hospitalization, any cause hospitalization or death. Benzodiazepine significantly increased risk in all three outcomes. Methylphenidate was also associated with lower all-cause mortality, but this wasn't a primary outcome. A combo of 2 or more substance use disorder meds, Vyvanse and buprenorphine, were associated with a lower risk of any hospitalization or death. This is interperson variability. So compared to periods when the same individual was not taking the meds, if they were getting multiple substance use disorders treated, they were on Vyvanse or they had buprenorphine, they had a low risk of hospitalization or death. So this is just talking about the doses of Vyvanse that they used. So it's licensed for 30 to 70 milligrams for ADHD. These green stars here are where they were seeing the decreased hazard ratio is better and an increased hazard ratio is worse. And so these green stars here show when we're between 45 and 85 milligrams, that's when we were seeing the real benefit in both the risk of hospitalization or death or hospitalization due to a substance use disorder. They did not see that same effect at the very low doses and at higher doses. So this is, again, it's kind of been compared to buprenorphine. Could this have a similar agonism type effect? And I think this was a good graph to remind us how much of an effect we do see from buprenorphine and the lack of some of this that we're seeing from stimulant use disorders. And
It's not the same.
It's nowhere near the same.
Yep.
It's just nowhere near the same. So with these studies of buprenorphine, we see a really significant decrease in opiate use when people are on the medication and able to retain medication for a long period of time. I think something else to consider about this is particularly looking at prescribed prescription psychostimulants is a risk for harm with these, and what could that potentially be? We've all certainly met people who had a use disorder consisting of prescription psychostimulants. This is just a paper, systematic review, looking at some information on that misuse and diversion. So they looked at a number of systematic reviews here. In 2008, this explored past year stimulant misuse in a general population. So this has been consistent across a few studies, but when you look at a school age and really young population, the misuse rate is quite low. That goes up significantly when you're looking more at an adult population. Overall, 11 to 29% have sold or prescribed stimulant medication. 23% of young adults prescribed stimulants for ADHD have been asked to sell, trade, or give away medications. A 2012 systematic review found a 44% misuse rate based on one adult study. But when they looked at a much younger population, ages 10 through 21, a 3% misuse rate. A 2020 review found 4 to 35% of individuals reported non-medical use of their own prescription stimulant. Their meta-analysis of this data concluded that the misuse of prescription stimulants to be at 22.6% and the prevalence diversion to be at 18.2%. So I think these numbers are really important to consider when we're considering prescribing a medication for stimulant use disorder.
And these weren't people who were necessarily had a stimulant disorder. There was anyone
This
prescribed.
was just people prescribed
Yeah,
it
exactly.
specifically for ADHD, which is where we saw the most benefit
Yeah.
from these other studies.
Yep. I'd just be curious if there's any data on the rates of, so hard to know,
Mhm.
the misuse of people who have a stimulant disorder diagnosis as well as ADHD. I wonder if it's more common or not. I don't know.
Mhm.
Yeah.
I'm sure there's some data out there on it. I didn't.
Yeah, just curious.
Well, that's it for my slides covering the actual data, but I was hoping to have some discussion with people about what everyone kind of thought about the data. If anyone has any questions or wanted to review any of the studies we just talked about.
Pam, do you have a comment? I definitely have some thoughts, but
Could you just kind of summarize then of all these
Like your takeaway.
studies?
Yeah.
Sure,
You know-
my takeaway personally is that I think there does seem to be certainly be some evidence for treatment of co-occurring disorders. If we're looking particularly at prescription psychostimulants, if we're looking at that population with ADHD, then we may see some benefit for that population.
Mhm.
Referring back to the ASAM guidelines, there does seem to be, potential for some of these medications, again, when we're looking at co-occurring disorders. So looking at co-occurring tobacco use disorder, depressive disorder, I think these all seem like very legitimate indications and reasons to give these medications further consideration. If there may be any benefit, and we're going to be treating depressive disorder anyways, alcohol disorder, that we can give these medications further consideration. It doesn't seem like there's much that we can tell a patient that there is good evidence that we are going to substantially reduce the risk or, significantly reduce the risk of ongoing stimulant use disorder, or that we're going to improve it with the medications that we have right now. I just don't see that there's good evidence for that. Regarding the prescription psychostimulants, these studies are showing us some benefit of these kind of robust doses. Just when you break it down, I mean, we're talking about prescribing greater than indicated doses of a controlled substance for a non-FDA approved indication. And I think that's really hard to do right now if we're just treating stimulant use disorder. And it seems that the evidence is only there potentially to treat like co-occurring ADHD. That is something we could give consideration to, but I can't see any way that would not be prescribed as, frankly, like a kind of, if you call it pill mill type situation, if we're
there's risk.
those not FDA approved.
I mean, I think these guidelines came out and we saw some shifts in practice due to them.
Mhm.
People saw, oh, stimulants for stimulant use disorder. Okay, let's go, let's try this. Because I think they're desperate, right? For
Mhm.
this, methamphetamines made a huge comeback. And they're just trying to figure out what on earth they can do. And so I think they're turning to this saying, okay, it's in the guidelines, let's try it. And the patients like it
Mhm.
because you're giving them a stimulant.
Right, the patients are.
But that doesn't mean it's actually good,
Mhm.
right? They will come back more often if you give them a stimulant, of course. Like if you are prescribing opioids at your door, your patients will come back to you every single week if you ask them to. Does that mean you're actually helping? So we have to be careful that them just coming back and being happy about it, we don't equate with success automatically. Now, retention and treatment is a good thing.
Mhm.
But we have to be careful that because we're giving them basically a substance that they're gonna like, that might be the only reason they're coming back. And are they actually improving? We have to be
Mhm.
careful about.
Mhm.
I think that's something we have to, that's just my thought.
Yeah.
I agree. I normally go by, do they have a co-occurring? And that
Mhm.
guides my treatment more than just, I'm treating just the stimulant disorder, because almost everyone's got something else going on.
Mhm. Yep.
And the ADHD thing's really hard because so many people think they have ADHD.
Yep.
And especially if you had a long history of stimulant use,
Mhm.
your attention, your focus, it's gonna be all over the map, especially in early recovery. And so it's really hard to differentiate.
And I think a lot of patients now, there's a lot just in the community and
Oh, yeah.
social media.
They all have ADHD. Yep.
Get your adult ADHD diagnosed,
Yep.
and there's a lot of those messages kind of being bombarded to
Yep.
patients anyways. So I think that's probably driving some of the increase in
Yep.
asking about it.
Yep. And keep in mind that if we do consider them, we generally are looking at the longer, things like the Vyvanse or methylphenidate, and avoiding ones that have a little more abuse potential, I think.
Mhm. Mhm.
Yeah.
And kind of like we talked about, my other takeaway was that, there's just not good evidence when you look at the risk of psychostimulants, and you wonder if these were widely prescribed, even if some people are benefiting, how many use disorder
Yes.
potentially contribute to create
Yep.
by putting these into our community when there's such a
Yeah.
diversion rate.
I don't see any comparison of number
Mhm.
needed to harm here compared to
Yep.
number needed to treat. There
Yep,
really isn't.
exactly.
And I agree.
Right.
Probably. would be not favorable.
Yeah.
It'd be actually a good study if someone did that, looking at how many, diversions and how many increases. Yeah. It's probably not
In
that,
patients with stimulant use disorder to start with. You mean?
or not, just like how many patients you have to prescribe stimulants to have somebody have a stimulant use disorder.
Oh, yeah, yeah.
Then just look at the rates of it, right? You can probably figure that out and then compare that to how many you need to give to reduce use. I mean, just, again, not, there is some evidence and this will grow, right? Well, we're doing a lot of stimulants right now out there for addiction purposes. So I do think we're gonna see a lot more data coming out. But yeah, the evidence isn't strong enough for me to be like, this should be our first thing.
No, not at all.
Not at all.
And I think we need to be more creative in terms of the contingency management, which is clearly shown.
Yeah, I wish it was easier.
Yeah.
There's so many regulations and they need to kick
You
back
can't,
laws and
you
stuff.
just don't get
Just
payment back.
do it.
Yeah, it's so difficult. So I would love to have one here.
Yeah,
So
or I feel like I've heard of lots of different stuff trying to use tech creatively to utilize it, but it feels like all those have kind of got off the ground and then failed and seems like a space that would be interesting to explore, but
So what is the VA using for their contingency?
just traditional as far as I'm aware. I haven't checked in with them recently about it, but just as, they have a group, you come in and you do a urine screen and they have they used to do raffle. They had like that's how they used to do it. I don't know if that's still the method. You get a certain increasing number of tickets, depending on how long you went without use. And then some more chances at the raffle, essentially. And there would be like one, really great prize and a lot of small ones, like a free coffee at the canteen, are most of the things. You'd always get something generally from the raffle, but most of them are very small. But some of them would be big, you could save up stuff. So it gave some incentives to.
it's like gambling psychology for good.
Exactly, that's the idea. That's the idea. And also like increasing rewards. Like the longer I do this, better chances I have.
Yeah, I know Hennepin's got
That's
kind of
what they're
a,
doing, yeah.
They're doing the Matrix, I thought. No?
They-
Trust, I think.
it's called trust. There's kind of a contingency element of it. It's,
Yeah.
the rewards are lower than they wanted them to be just because of funding stuff, but they do have some financial rewards.
I think it's like however much, like 10 for coming to the appointments or groups, and then like 20 or 30 if they have like a negative MBS.
Yeah, there is some data out there that the higher the reward, the better.
People respond better.
Yeah, so it does matter some. But I don't know, what about your thoughts, Pam? Has this changed your practice at all, like these guidelines or?
I've always been sort of against the idea of using psychostimulants to treat stimulant use disorder, just because I'm concerned about risks. But I think trying some of the non-stimulant therapies might be reasonable. More, even though there's low certainty. I mean, I think it would be, particularly with co-occurring, if there's a co-occurring mental health disorder, like you said, that's an important consideration. But I think, and I guess the dose concerns me a little bit too, that you have to use high doses. So, I think that makes the risks of developing a use disorder if you don't have one, or of diversion higher. So,
Or having cardiac problems, I mean, honestly.
yeah, or having, right, some other complications. So, it's until we have some better, stronger data, I guess, I'm hesitant to
Yeah.
use psychostimulants. I mean, it's the same idea as, people have sort of, traditionally been against using methadone to treat opiate use disorder. That idea, I mean, so unless we did it in some kind of a very controlled way, like we do with methadone, or else, had a partial agonist or something, that would be nice. Someone should develop that,
There you
like
go.
like a buprenorphine-like drug for stimulants. Um, but, I think we don't, like you said, we don't utilize contingency management enough because is the one thing that's been shown to have significant evidence. So I don't know.
Yeah, no, I think that latches up a lot what we're thinking here too, Pam. I'd love to hear just your personal opinion on ADHD and stimulant use disorder. Like, what
Mhm.
is your threshold for considering using a psychostimulant for that? Especially when our diagnoses are often we don't have full data. I'm just curious how you handle that because that comes up all the time now.
Yeah, I really try to use non-stimulant or um, non-stimulant medications, for ADHD in patients who have substance use disorder. So, um, I think that I just don't, I guess it's the do no harm thing
Yeah.
of introducing another addictive medication to someone who already has a substance use disorder, even if they have ADHD. I think it really kind of depends on making the solid diagnosis. And like you said, I don't think that's easy to do if they've been using substances or if they are showing up as an adult and saying, gee, I'm having trouble focusing, you know, but they're drinking a gallon of liquor a day. Well, I mean, I think,
I think we
yeah,
can't lose sight of
so,
the fact that psychotherapy therapy is effective in
Yep.
treating ADHD, and you
Mhm.
have specific therapists. That is what they do.
Yep.
Yes,
yeah.
they're making the diagnosis, and that's hard enough to do. But
Hmm.
but we do have a therapy specifically for ADHD.
And a lot of these patients
Hmm.
definitely benefit from it because they're
Mhm.
organizational and ability to keep appointment. All those things are
Mhm.
not.
I mean, the
generally-
fact that, we've got these highly structured studies, and I know you've heard me say this before, but some years ago, I did a trial of lisdexamfetamine. Population was cocaine users who had ADHD.
Here.
Yeah, 70 milligrams was the dose. And it was cocaine.
Yeah.
It wasn't amphetamine type stimulants.
Mhm.
And
And
what did you give them?
70 milligrams of Vyvanse,
Mm-hmm.
and they got CBT as well. And it was pretty clear that it was effective for their ADHD, but it was not effective in reducing their cocaine positive neurons.
Hmm.
So, even when we have these really highly
Yeah.
controlled trials, you think if you're going to see a positive result, you're going to see it kind of in that framework. They're coming in for their visits. So you've got that continuity, and you're doing some therapy because you do therapy in the context of these trials.
Hmm.
And even at that, not seeing any
Yeah.
kind of robust results.
Well, a lot of these studies were small. I mean, there were some well-designed ones,
Mhm.
and the fact that we haven't seen a larger signal,
Mhm.
I mean, you could say they're underpowered, you can say all these things, but I mean, what our meds that do work, we see much clearer signals overall. So I would look at, for me, the co-occurring. If you're gonna get some benefit here, maybe consider it. But yeah, straight for stimulant use disorder, it's very
Mhm.
low. And personal, this is my personal practice. It hasn't, even though with that Swedish cohort with the Vyvanse, I was kind of excited when I saw that. But
Yeah.
if you look, as you said, the Vyvanse data isn't strong on its own. And if it was there, I feel like we would have seen it. It's not like a new concept, not like stimulant misuse is a new problem. We've been studying this for what, 5, 6 decades. Like, that's why it's like, what's the big brouhaha now that all of a sudden this is the treatment of choice I don't get for some clinics. I get why they're doing it out of desperation, but I think maybe we gotta be careful. That's just my view on it. Someone to chat?
Yeah, Danielle said, of course, very patient specific, but I'm curious in general how
Yeah.
receptive patients are to a non-stimulant option for
Less
comorbid.
now than they were even a couple of years ago. I feel like much more pressure to give a
Yeah, I
stimulant.
asked because I feel like I sort of see, well, they leave and then they go to a different provider, or
Yeah.
there's some going around to different providers
Yeah,
trying to
And
find
even in
more.
treatment centers now, there's pressure to prescribe stimulants in active, like early recovery. I mean, I agree. It's hard to say no to people. And patients get more upset about it and less receptive to non-stimulant options. We have patients leave the clinic specifically because we're just like,
Mhm.
don't think, maybe if we work with you, we find and confirm the diagnosis, let's treat everything, and make some progress, and they'll just be like, nope, and leave.
uh-huh.
Most don't, but some do. What
I
about your
think
experiences?
when you mention therapy, psychotherapy for ADHD, Sheila, are you talking about some specific approach or for patients with ADHD that
Oh, I think there's a lot of CBT involved in the therapy
mhm,
for ADHD. I know that there are some therapists that's their thing. That's what
Yeah.
they do really well. And we refer people to
We even had some tests for some patients with occupational therapy,
occupational
specifically for
therapy, yeah.
ADHD.
Right.
It's the
Yeah.
problem is access, but yes, there are some actual therapies that can be very beneficial for patients if they're willing to engage. It's the question of finding. But yeah, we had an
Right.
occupational therapist here for a while who did ADHD. We had some patients who really
Yeah.
loved it. Thought it was the best
I
thing they'd
thi-
ever done. So
Yeah. Even for kids, I think with ADHD, there's been some effective therapies. I just didn't know if there's a specific name for that or if it's just certain therapists that have sort of specialized in it or
I don't know if it's a
if-
specific name.
There's a
Yeah.
specific name.
But we just saw a
It's a lot
flyer.
of-
There's a free 6 to 8 sessions in the Wheel Foundation right now. We just saw a flyer show up for ADHD therapy.
huh,
The Wheel Foundation.
It's
for adults.
I don't think if it's specified. I'll have to look at the flyer again. It's in our office. We just got it. Yeah.
Oh, okay.
But it's yeah, I don't know what the Wheel Foundation is. It's something with the university, but 6 to 8 sessions
Okay.
for free. Patients based.
Really?
Yeah,
I'd be interested to know more about that too.
sure.
So Katie, did you run into anything on vaccines?
Is for specifically.
Okay.
For stimulant use disorder?
For stimulant use. Yeah, because for a while, cocaine, so Hannaford was working on vaccine cocaine. And I don't know when that dropped off.
I sure didn't search for that specifically.
No, it's
so-
vaguely reading it all, but.
I'm not asking
No.
back up. What would you target?
I'm so.
I don't know.
Yeah.
I can't remember.
I mean, they've looked at vaccines for a bunch of substances. The problem with them has just been, there's so many variants of these substances that they're not gonna work. Like the fentanyl vaccine, I think was never gonna work because there's just too many new things coming out. And for stimulants too, there's a lot of novel stimulants coming out in the markets, Captic and everything else. So I don't think methamphetamine, for instance, would really hold water long term, but cocaine,
Yeah,
maybe.
this was for.
Cocaine is a
specifically
little more of a
cocaine.
unique kind of pharmacology, actual structure. It's why on the UDS, it's one of the few things, if you see cocaine in a urine drug screen immunoassay, it's pretty much cocaine.
Mhm.
One of the few ones that has few other positives. Yeah.
My immediate thought on that is you run into a lot of these patients with like a cocaine use disorder that just pivot to Adderall when they don't have access to cocaine.
Well, yeah.
again, But they just
They just start using that.
use something else.
Yeah,
Yeah,
that's true. Not gonna block that.
yeah.
That's a fair point.
You get enough molecules across the brain barrier and,
Yeah, it's not easy.
they're big molecules.
Yeah. Good question. Well, thank you, everyone.
No.
Anybody else? For any last thoughts? Okay, well, thank you guys.
Great question, Danielle. Thank you, because it is a problem with patients.
Thank you for the information and presentation.
Thank you, Katie. Do you have a list of these references?
Yep, it's my last few slides. There's 14 of them in there.
Okay, it'd be nice to have those. Are
We'll
you
post it
willing?
up on the MNSAM website.
Yeah, I was gonna say, are you willing to put these
Yeah.
slides on the
Yeah,
MNSAM
put the slides
website?
and the recording both. We'll put them up. So.
Great.
All right,
All righty.
thank you, everyone.
You should end the recording, by the way.
Yeah.
Yeah, and.
Yeah.
Okay, thanks. Thank you, Katie.
Oops, go to the more.
We'll figure out something for next month.
Recording first.
You see that? There's a
Just
button.
right here.
Just stop recording
There you go.
in there.
Okay.